Hi, my name's Dr David Treagus, and I was hoping to share a case with you on My Vermilion. And one of the great things about My Vermilion is that it gives us the opportunity to share cases like this one, really interesting cases that we see on a day-to-day basis. So this patient was referred to us because he had a tooth that was root treated when he was a child, and unfortunately that was persistent infection. I diagnosed apical periodontitis on his lower left 6, and although he had no symptoms, he decided to re-root treat the tooth to prevent future pain. So you can see on the radiograph prior to treatment that there is a large apical radiolucency on the end of the tooth, mostly situated from the mesial canal, but extends towards the distal. You can see that there is a poorly condensed root canal filling in the mesial canal, which is short of the radiographic apex. The challenge I was expecting when I saw this x-ray is that I was worried we may not be able to gain patency in the mesial canals because there's no obvious canal past the old root canal filling. And so my plan for this tooth was to initially dismantle and assess the tooth, and I hadn't noted any obvious cracks or any obvious reason why I was unhappy to continue with the root treatment. I then built up the lingual wall with composite resin, and that gave us a nice 4 walls for single tooth isolation in future for root canal treating this tooth. Next, we started removing the previous root canal filling. To do this, I used both R25 files and also Headstrong files, and the root canal filling on the distal was removed uneventfully. In the mesial canals, once I'd removed the old root canal filling, I could feel with my hand files that there was this really big curve, and I wasn't quite sure what was going on. So at this point, we agreed, let's take a cone beam CT scan to try and work out the entire anatomy in that mesial canal system. On this scan, you can see the tooth that we were in the middle of root treating. You can see the mesial canals on this top left screen, and you can see there's 2 canals here which join to one in the apical third. And as we scroll through here, you can see here's the buccal, and this is the apical extent, and then you can see it joins together on the lingual. And then if we look on this view down here, you can see we've got 2 separate canals, one here, one here. And as we're scrolling down, you can see they join together to make one canal. And then past that, you can't really see any patent canal. So I knew that my work was cut out to gain patency on this. So to gain patency in the mesial canals, I used a combination of C+ files and EDTA. The EDTA to soften the dentine, the C+ files with their cutting tip, they work their way down the canal system inside that tooth. And I could actually feel, in fact, there were 2 portals of exit in the apical third of this tooth. And so, although that wasn't clear on the cone beam CT scan, on our post-op obturation, you can actually see this quite clearly where the canals do split off into 2 canals in the apical third. The main canal, it was possible to prepare with a Wave 1 gold files, but on the second mesial canal, I had to use ProTaper hand files because the curve was really quite abrupt and it was really challenging to get my files into that canal system using normal rotary files. So you can see on the pre-op x-ray the poorly condensed root canal filling that I was talking about in mesial canals. You can see that it was short of the radiographic apex on the mesial. You can also see that there wasn't any obvious patent canal in the mesial. However, on our post-op x-ray, you can see where there are these 2 canals joining to one in the mid-third, and then it splits into 2 in the apical third. On the distal and the pre-op x-ray, it looked pretty good beforehand, and so I was quite happy with how it looked, and we're looking very similar in post-op. So it really shows the importance of not only having a cone beam CT scan, but also really good tactile sensation, tactile feedback when you're using hand files to make sure that you can feel what's going on in the apical third, because of this anatomy here wasn't actually as obvious on the cone beam CT scan as we would sometimes expect because the canals were so sclerosed. I've really enjoyed going through this case with you guys today, and I hope you've enjoyed it too. If you ever have any questions or anything you'd like to ask us, please get in contact either by email or through the My Vermilion website. And if you have any questions about this case, please ask away.